Hi friends. Welcome to Dentistry Love Channel, Full Mouth Rehabilitation presented by Dr. Manohari. Synopsis include definition, indications, contraindications, diagnosis and treatment planning, diagnostic aids, 10 steps involved, advancements. Definition. Full mouth rehabilitation is defined as the restoration of form and function of masticatory apparatus to as nearly a normal condition as possible. Multidisciplinary approach includes endodontic, prosthodontic, orthodontic, periodontic and oral surgical procedures. Goals include healthy, PDL, aesthetic, well-functioning, TMJ, and self-maintaining. Indications. Restore impaired occlusal function. Preserve longevity of remaining teeth. Maintain healthy periodontium. Improve objectional aesthetics. Pain and discomfort of teeth and surrounding structure. Contraindications. Prescribing a full mouth rehabilitation shouldn't be taken as preventive measure unless there's tissue breakdown. Malfunctioning mouths that doesn't need extensive dentistry and have no joint symptoms should be best left alone. No pathology then no treatment. Diagnosis and treatment planning. First appointment includes: listen to patient's opinion and expectations. Make diagnostic casts and radiographs. Bite records and FABRICATE transfer. Tentative treatment plan is made. Second appointment includes: individual teeth is meticulously examined. Scaling. Extracted or restored. Serve as abutments for RPDs or fixed prosthesis. Diagnostic aids include a medical and dental history. Behavior evaluation. Complete full mouth periapical radiographs and OPG. Photographs, to remind previous state of mouth prior to restorative therapy. Clinical examination. Diagnostic wax-up. CBCT. Computer imaging. Cephalometric analysis. Treatment plan includes 3 phases: pre-prosthetic phase, prosthetic phase and maintenance phase. Pre-prosthetic phase includes oral prophylaxis and oral hygiene instructions, caries control, necessary extractions, minor tooth movement, equilibration. Prosthetic phase includes immediate treatment and definite treatment. Maintenance phase includes advice scaling periodically. After maintaining adequate oral hygiene, patient is recalled at 1, 3, 6 and 12 months. After 1 year, patient is recalled annually for checkup and prophylaxis. 10 steps involved. Data collection and diagnosis. Mount upper cast with correct orientation relation. Deprogram and mount lower cast with centric relation. Finalize vertical dimension and get diagnostic wax-up commissioned.
Fabricate bonded mock UPS or provisionals. Decision-making for final restorative material. Volume-based tooth preparations. Tissue management, impressions and bite records. Bonding/delivery. Diligent occlusal management. Data collection and diagnosis. Clinical examination, radiographic examination. Full dental photography and preoperative video analysis must be carried out and findings charted. If implants are needed, a CBCT will be added to the data in the early stages. Cephalometric analysis is needed at this stage to evaluate the preoperative vertical dimension of occlusion and overall jaw and teeth positions. The musculature as well as TMJ examination is done to ascertain a negative load test. In cases where load test is positive, splint therapy is recommended. Most cases with pain in TMJ region could be muscle-related problems that get solved with diligent deprogramming. Mount upper cast with correct orientation relation. Once the diagnostic casts are made, the upper cast must be mounted with a FABRICATE record that allows aesthetically correct orientation relation. The pre-existing cant in the maxilla must be recorded in relation to the facial midline to allow accurate decision-making regarding the midline and the axial inclinations of the upper anterior teeth and an upper occlusal plane that is parallel to the horizon. Deprogram and mount lower cast with centric relation. The patient must be deprogrammed before the centric bite record to allow the jaw relation record to be taken at optimal joint position. An alu wax wafer may be used to record the centric relation. Using alucia jig or cois deprogrammer may be used to record the CR at an increased vertical dimension of occlusion. Finalize vertical dimension and get diagnostic wax up commissioned. Aesthetics, phonetics and cephalometrics combine to give the required guidelines for the increase in vertical dimension of occlusion for cases with generalized wear. Judicious changes in VD will allow the tooth preparations to be conservative and allow the vitality of most teeth to be maintained. Changes in VD are well tolerated in patients with healthy joints and when there is friction-free stable occlusion. Diagnostic wax up. Once an empirical vertical dimension is arrived, the case is sent to the lab for diagnostic wax up. All the changes that are desired in the case must be achieved with the wax up. Restorative designs, onlay, veneers or full coverage must be finalized during the wax up. Fabricate bonded mock UPS or provisionals. The ideal requirements of these provisional restorations are that they can be made without any tooth preparation. Usually the lab fabricated, indirect, provisional restorations are made in form of an overlay on the whole arch. Direct techniques, however, offer some advantages as these can be bonded intraorally and thereby allow a perfect test drive for the final aesthetics and occlusion. Provisional restorations. The patient should be allowed to use the provisional restorations for a couple of weeks, and at the end of that period, if there are no negative signs reported in the musculature or the joint, phonetics is comfortable and aesthetics acceptable, the clinician must record the approved provisional in form of digital data or an analog impression that can be used as a guidance in the laboratory. Decision-making for final restorative material. Porcelain fused to metal, zirconia and lithium disilicate are the various options for the final restorations. It is important to mention that the material that needs the least tooth preparation to provide the most durable and aesthetic result must be chosen. If occlusal clearance without excessive tooth prep is not an issue, it could be monolithic or stained lithium disilicate for posteriors and layered option for anteriors. If clearance is on lesser side, zirconia may be the chosen option, as it would be also in case a bridge in stress-bearing area had to be fabricated. Volume-based tooth preparations, procedures such as endodontics, fillings and post and cores as needed are done quadrant-wise. The provisional restorations from one quadrant may be removed by cutting them off. In this way all the required teeth are treated and the patient is now ready for the definitive impressions. The final impressions for all the teeth for full arch restorations can be done at one time. Tissue management, impressions and bite records. Tissue management could be done with gingival retraction cord soaked in aluminium chloride. Digital or analog impressions are taken for the upper and the lower prepared teeth. The bite record is done on the posterior teeth while the Lucia jig is holding the vertical dimension as an anterior stop. A FASPO record should be done again to orient the maxillary working cast in an aesthetically correct position. Bonding or delivery trials should be carried out and the final checks performed to verify aesthetics. Proximal contacts must be checked and occlusion marked to see that uniform equal intensity bilateral contacts are achieved. After final glazing, the restorations are bonded using the adhesive protocol. Enamel should be etched for 15 seconds with 37% phosphoric acid and the dentin for 5 seconds. Dual cure resin cement must be used on the silanated intaglio of the lithium disilicate restorations that are thicker than 1 mm to allow all resin to cure. Diligent occlusal management. Occlusion check must then be performed with 40 micron articulating paper. Final finishing of occlusal contacts should be done with 8 microns. The incisors must be adjusted to not hold the shim stock. All the surfaces that are adjusted after bonding must be polished using a dedicated system for intraoral finishing and polishing of lithium disilicate.
Thank you, friends. Please do subscribe for more videos.